During pregnancy, dental procedures often require local anesthesia, and both ACOG and RCOG provide guidance on this to ensure the safety of both mother and fetus. Here's a detailed look into using local anesthesia in dental procedures during pregnancy according to these guidelines and evidence-based medicine. 1. Safety and preferred agents. Lidocaine. ACOG and RCOG recommend lidocaine as the preferred local anesthetic due to its long-standing safety profile in pregnancy. It's classified as a Category B drug by the FDA, meaning animal studies haven't shown risk to the fetus, and limited human data suggests minimal risk. With or without epinephrine. Lidocaine is often used with a small amount of epinephrine adrenaline, which helps localize the anesthetic effect and reduce systemic absorption. Epinephrine use should be cautious but is generally safe in low doses. Both ACOG and RCOG recommend using the smallest amount of anesthetic necessary to achieve effective pain relief, minimizing fetal exposure. Evidence-based findings. No increased risk of birth defects. Studies support the use of local anesthetics like lidocaine without an increased risk of miscarriage, birth defects, or preterm labor. 2. Trimester-specific considerations. Second trimester. Dental procedures are ideally scheduled during the second trimester, 14 to 28 weeks, to minimize risks. This timing avoids the period of early organ development, first trimester, and the physical challenges of lying flat in late pregnancy, third trimester, both of which may pose higher risks. First and third trimesters. In cases of urgent need, local anesthesia can still be used safely in both the first and third trimesters. However, guidelines suggest avoiding elective procedures early in pregnancy to limit any risk to fetal development, and late in pregnancy pregnant patients should be positioned comfortably, avoiding lying flat on their backs for prolonged period in late pregnancy to prevent vena cava compression.
Here's a detailed overview of systemic and topical decongestants according to the latest guidelines, including safe alternatives for managing nasal congestion in pregnancy. 1. Systemic oral decongestants. Oral decongestants can provide relief for nasal congestion, but their use in pregnancy should be limited due to potential risks. Guidelines generally discourage use in the first trimester, with cautious consideration after that. Pseudoephedrine. Pseudoephedrine is a vasoconstrictor that reduces blood flow to nasal passages, helping to relieve congestion. Guideline recommendations. ACOG and other guidelines generally advise against pseudoephedrine use in the first trimester due to a potential risk of gastroschisis, a rare abdominal wall defect. After the first trimester, it may be considered a few days if symptoms are severe and other options are ineffective. Phenylephrine. Similar to pseudoephedrine, phenylephrine acts as a vasoconstrictor, reducing swelling in nasal passages. Guideline recommendations. Generally not recommended during pregnancy due to insufficient safety data and potential association with birth defects. Avoid during pregnancy, especially in the first trimester. Only considered as a last resort if other decongestants are not effective. 2. Topical intranasal decongestants. Topical decongestants are generally preferred over oral options because they act locally, minimizing systemic exposure. However, they should still be used cautiously to avoid rebound congestion, which can worsen symptoms if used excessively. Oxymetazoline (Afrin) constricts blood vessels in the nasal passages, reducing congestion locally with minimal absorption into the bloodstream. Guideline recommendations. Considered safe for short-term use across all trimesters, making it a common choice for nasal congestion during pregnancy. Use recommendations. Use for no more than 3 to 5 days to avoid rebound congestion, rhinitis medicamentosa. Xylometazoline acts similarly to oxymetazoline by reducing nasal passage swelling and congestion. Guideline recommendations. Recommended as a short-term option and safe across all trimesters when used sparingly. Use recommendations. Limit to short durations, 3 to 5 days, to prevent rebound congestion. Nafazoline works by constricting nasal blood vessels, similar to other topical agents. Guideline recommendations. Used less frequently, but some guidelines allow for occasional use if other decongestants are ineffective. Use recommendations. Use only under medical advice and for short periods due to rebound risks. Phenylephrine topical reduces nasal swelling through vasoconstriction. Guideline recommendations. Not typically recommended due to limited data, though it may be a secondary option if safer options are not available. Use recommendations. Only under healthcare provider supervision, for short-term relief, if other topical decongestants are not effective. Ephedrine topical, similar to pseudoephedrine but acts locally to reduce nasal passage swelling. Guideline recommendations. Rarely recommended but may be considered in certain cases if other topical agents cannot be used. Use recommendations. Should only be used under strict medical guidance and for limited durations. Intranasal corticosteroids for nasal congestion in pregnancy. ACOG. Intranasal corticosteroids like budesonide and fluticasone are generally safe with minimal systemic absorption. RCOG. Supports use if benefits outweigh risks, consistent with safety principles for pregnancy. Evidence-based medicine. Studies show no increased risk of major malformations. Budesonide has the strongest safety profile. Recommendation. Use the lowest effective dose and consult if symptoms persist. 3. Safer alternatives for nasal congestion relief. Non-medicated options are usually recommended as the first line of treatment, as they are free of risks and can often effectively relieve mild to moderate congestion. Saline nasal sprays. Guideline recommendations. Recommended as the first-line option due to their safety and effectiveness. ACOG and other guidelines endorse saline sprays for frequent use. Mechanism. Moisturizes and clears nasal passages without medicated ingredients, relieving congestion by loosening mucus. Use recommendations. Can be used freely without restrictions for symptom relief. Steam inhalation. Guideline recommendations. Safe and effective, endorsed as a natural remedy for nasal congestion relief. Mechanism. Steam helps thin mucus, which can help clear nasal blockage and ease breathing. Use recommendations. Inhale steam from a bowl of hot water or humidifier. Adding eucalyptus oil is optional, only a few drops if used. Humidifiers. Guideline recommendations. Recommended, especially in dry climates or during colder months, to maintain moist air. Mechanism. Adds moisture to the air, preventing nasal passages from drying out and relieving congestion. Use recommendations. Use in the bedroom or other living spaces to keep the air moist, especially overnight. Warm compresses. Guideline recommendations. Safe and effective as a home remedy to soothe nasal passages. Mechanism. Applying a warm compress across the sinuses can relieve congestion by reducing swelling. Use recommendations. Place a warm, damp towel across the sinuses for a few minutes, repeating as needed.